Okay, hi everybody. This is Carol from the Society of Thoracic Surgeons. This is the Adult Cardiac Surgery Database monthly webinar for January 6th. We're going to get started now. Thank you for joining. I hope everybody had a wonderful holiday season and a happy new year and was able to unplug for just a little bit and come back to work feeling refreshed. Today on the webinar call with us, we have our Iqvia team, Jean, Joe, and Melanie. And from STS, we have Jane, Addie, Emily, Leanne, Sydney Clinton, and Melinda, who runs our FAQ mailbox, and myself. So thank you for joining, and we'll get started first. A quick run through of the agenda will be the STS important dates, and then we have some education, and then Iqvia update, and then Q&A. And quick run through of the important dates for adult cardiac. Today is January 6th. We have our monthly webinar. The user group call is scheduled for 2 p.m. Central on the 20th of January. The next monthly webinar is February 3rd. Harvest 1 2021 closes on February 12th. The opt-out date is February 15th. That will include OR dates through December 31st, 2020. So you'll have 6 weeks to get your 30-day, well, 2 weeks to get your 30-day follow-up in for those very late December cases. And then public reporting refresh will be in the spring of 2021, and that will include data from the Harvest 1 of 2020, which was end of calendar year 2019 OR dates with December 31st, 2019. Melinda and I are going to go over some of the education for January. The training manual and the FAQs were posted. The training manual and the FAQs were posted yesterday, so you could find the updated training manual there with the FAQ sheet. And there's a couple other things I wanted to talk about as well. So I'm going to make the screen a little bit smaller in case I want to pull something over. For those of you who are familiar with or aren't familiar with how the training manual works, this is the Adult Cardiac Surgery Database on the STS National Database page, which is the fourth blue tab from sts.org. So sts.org, Registries, STS National Database, and you'll come to the database homepage, and then select Adult Cardiac, access data collection resources, and we're in version 4.20. And here's where you'll find the updated January 2021 training manual and the FAQ summary. The FAQ summaries we've put together, Melinda's put together this nice kind of cheat sheet for you, and it includes January's FAQs. And if you continue scrolling down, you'll see December's all the way through the beginning of version 4.2. July, it goes all the way through July. So these are also bookmarked in the training manual. So if you're to open the training manual and click on this link, you'll be directed to, hold on, sorry about that. You'll be directed to the training manual. It'll open on this page. There's a couple links here that are quick links for you. You can find public reporting, or if you need contact information to reach out to one of us, info on the monthly webinars, or data. If you need to ask Melinda an abstraction question, all quick links are here. And if I'm in Chrome, there you'll see this bookmark tab over here, and it'll take you to all the sections are bookmarked, and then the sequence numbers where the updates were applied or provided are also bookmarked. So the first one I wanted to talk about was the sequence 500, which is the cancer within 5 years. The FAQs are highlighted in red. And you can see here, we talk about melanoma skin cancer, and we say, should this be coded as a cancer within 5 years? And the reason why this came up is because in the definition, we specify that we're not to capture low-grade skin cancers such as basal cell or squamous cell carcinoma, but we don't address melanoma. And melanoma is considered a high-grade skin cancer, so it is not considered a low-grade skin cancer. We reviewed this with the surgeons, and we are to capture melanoma within 5 years as a yes for cancer within 5 years. So I wanted to go over that one just to clarify that, make sure that the reason why a little bit of extra information may be needed and it's not always clear is that We talk about skin cancer in one spot, and this happens in other FAQs as well. We talk about something up in the definition, we provide an FAQ, and sometimes it can get a little hairy if we aren't real very specific. If it could appear as there's conflicting information, but there's actually we try to make it clear. So if there's any FAQ that you see that is conflicting, Melinda does a great job at providing very clear language, but we're always open for suggestions. So I just wanted to point that melanoma out related to it being a high-grade skin cancer. The second one is the hemodynamics, and I'm going to let Melinda explain this one. Oops, sorry about that. This is the coding of values if not all values are available on the one test closest and prior to OR entry. And I'll pull up, so I'm going to go here, and you can see the January FAQ. It says, can or should values from earlier echoes be used to complete data variables not present on the most recent pre-op echo? For example, an echo was performed on 8/29/20, which was done 1 day pre-op. However, it doesn't mention or address the aortic insufficiency. Previous echo was performed on 6/26/20, and it does document aortic insufficiency. How do we code aortic insufficiency? So Melinda, did you want to talk about this one a little bit further?
Well, yeah, I think the important thing here is that if you're looking for something that's not on an echo, so for example, this is a perfect example, aortic insufficiency, and the one closest to the OR doesn't have any mention of that at all. So, you could say that maybe the valve wasn't visualized, or maybe it just wasn't addressed. Maybe they didn't look at it. For whatever reason, it's not there. So you go back and you've got another echo that was done just a couple of months before that one, still within the time frame that's acceptable to code. And the aortic insufficiency is documented as trace on that echo. So it's perfectly acceptable to use those values that were not addressed in the echo closest to surgery. And so we had some questions come through the mailbox, and I felt like it was important to clarify that. So I'm hoping that this will clarify that. Please let me know if you have any additional questions.
Thank you, Melinda. I think you said that well. Hopefully this is one of the chemo and echo section is one of the areas we have the worst audit results on. And Melinda did a great job really working with the surgeons on getting source document priority for coding and providing some really great examples. So I suggest reading this if you think you know how to code. I guarantee that's probably something in here might be helpful to you as well. So just take a look and let Melinda know if you have any questions. So thanks, Melinda. The next one is this left atrial appendage, and we have two options here. We have the obliteration and we have the amputation of the left atrial appendage. So I wanted to pull that one up. This is 4139. It's under 4142 as well. And I'll show you what it looks like on the DCF. So this is under section M1. You have selected that a AFib procedure was performed up in the operative section, and then these questions will open. There's 4 that are children to that if an AFib procedure was yes. The first 2 are left atrial appendage obliteration and left atrial appendage amputation. If any part of the left atrial appendage is left in, that is not considered an amputation. So you should code that as an obliteration. And I'll let Melinda speak to this further. She provided some clarity in the training manual on this one.
Oh yeah, this came from a question came from a data manager, which was a really great question. I thought, she was like, she said, well, the LAA was amputated with a stapler, epicardial staple. So it kind of immediately created a conflict in my mind. Like, okay, so because an obliteration choice is the epicardial stapler, but in the surgery note, it said it was actually amputated with the stapler. So we went to the surgeons, we talked about this, and we thought we needed to have some clarity because we don't want people choosing both choices. You know, you either obliterated it or you amputated it.
Yeah.
So based on leadership, the decision was made that if any part of the LAA is left in the body, then that is going to be obliteration and not amputation.
And I think more specific on her question was that it was a cutting stapler, which means that it amputates the appendage, but it's a cutting stapler, meaning that it amputates the appendage and it staples it closed. So there's no bleeding or anything here. So that was kind of a confusing thing in her operative note.
Well, and it was confusing, and and I thought it was a really good point. I can't remember who brought that up to me, but I thought it was an excellent point. And so we've provided some clarity now. So if any part of that's left in, or if they use the cutting stapler, they don't remove the whole thing, they use the epicardial stapler, those are obliteration choices. Amputations when the surgeon just goes in there and cuts it out.
Great, thank you. And then Aorta Devices, this was related to sequence 5442. Let me pull that one up here. So this is an M2 section. This is the devices when we get to aortic valve or aortic valve composite graft implanted, yes or no, and we're looking for the implant. We're looking for the implant number. I see somebody just put something in that says no volume, unable to call in. If you don't have volume, I would try to reconnect it through the computer. The call-in number, if the 800 number is not working, there should be a non-800 number. And maybe Leanne, could you check on that and put it in the chat box?
Sure thing.
Thank you. Okay, so aortic valve or aortic valve composite graft for this implant number. The question that Melinda received. Clarification was the intent is to capture commercial valves and commercial valve conduits in this field.
And I can speak to that a little more if you want me to, because I think this has caused some confusion. So will you bring that data collection form back up? So in sequence 5442, this is for commercial valves or valve conduits. And there's actually a drop-down selection set. If you look at your data specs, you'll see everything that's listed in there. So the question came up when a surgeon takes a commercial valve and then he makes his own composite or conduit with some HemoShield. So how do you code that? And so in order to code that, you're going to put the commercial valve in sequence 5442 because there's a drop-down selection for that commercial product. And then if you scroll down on the form, you see at 5450 down here, this is where you're going to implant that HemoShield that he used to create his own composite or conduit, whatever you want to call it. Because things of that nature are not in the drop down above. They all go down here in this section starting at 5450. So HemoShields and Marquettes and all those different kinds of graft devices that are being put in the aorta that are not commercial conduits or valves go in 5450.
Okay, so Melinda, let's say that they did the surgeon fashioned one off of a commercial valve and then fashioned on a HemoShield graft. For the location, we're coding the most proximal locate. We're coding the proximal location in the first one here.
Mm-hmm.
Which would we code it as below sinotubular junction?
Well, I guess I would think that's where it would be because it would be attached to the valve. He's making his own graft. So yeah, I'm assuming that's where he would attach it at.
Okay, yeah, I agree. I think that's right. Okay.
And then of course we would also enter the most distal location. So if he went to the mid ascending. So for your first one, you put the HemoShield in below STJ. And then for the second one, you would put mid see mid-ascending, that's the most distal end. So we know that that graph went from the S to below the STJ to the mid-ascending.
Great. Thank you.
Welcome.
Oh, next one. Oh, my mouse is having I keep on thinking I can scroll on this page because it looks like a list. The next one is the temp YN2 field. This was just started on January 1st, and an email went out on December 22nd. I think we included this information, or right around then. We're using this field to code the ELS model 5300 PhysioFlex annuloplasty ring. This model was approved after version 4.20.2 went live, and our research center is wanting to collect data on this. We collect data on all devices, so it's not anything special for Edwards. It's just that we didn't have this one on the list when the version went live. And our research center is interested in specifically in this new device, so we're looking at that closely. And you can find it in the mitral section. So I'm just going to scroll up here to the mitral valve section. And you'll see it here. This is the mitral section. You'll see the implant field, and then we have was the device implanted PhysioFlex annuloplasty ring. If you had this field will show up on all of your patients, regardless if it was a mitral case or not, or if an implant was made or not. So for those cases where it doesn't apply, if it's not a mitral case, you can just leave it blank, and it will show up blank on your data quality report, on the missing variable report, but you can ignore it. If it is a mitral case and you did an implantation and it was a PhysioFlex annuloplasty ring, you'll code yes. And if no PhysioFlex annuloplasty ring was inserted, but there was other insertions for the mitral space, you could just code that as no.
Can I add one other thing, Carol, about this? So in sequence 3625, the model number. So if you implanted this, you're going to choose other FDA approved device there because it is FDA approved. And then you'll go down and say, was it this model? Yes or no. So because there are other devices that have also been approved after lists came out, which we will not be collecting temporary fields on at this point. The only reason we're doing this one is the research team asked us to.
That's right. Thank you for clarifying that. Thanks, Melinda. Oh, the next thing is the Carpentier classification, or the Carpentier type. We have used these terms type and class interchangeably on the DCF and in the data specs and in the training manual. And Dr. Badwar just asked that we clarify with everybody that it is, I'll show you where that's at. Whoopsie. Carpentier is a type, it's not, sorry, hold on. Carpentier is a type, it's not a class. So it should be read Carpentier type up here instead of class. It's not a big deal, but if you see language where they say Carpentier type 1, it's synonymous with class 1, or Carpentier class 2 is synonymous with type 2. Down here we use type 2 and type 3A for this mixed lesion. It means the same as class 2 and class 3A. So I just also wanted to point that out. No major change to the data collection form or specs or anything like that, just a wording issue I wanted to make you all aware of. And I think that was it for us. Melinda, do you have anything else you'd like to add?
I don't think so. Happy New Year, everybody.
Happy New Year. Okay, and I'm going to hand it over to Joe for the Iqvia update.
Awesome, thank you. All right, so Happy New Year, everyone. Glad to be here. We'll start off with some updates that were released last week, December 30th. So these updates are posted in the notifications section. So if you go there, you should be able to review these if you need to. So issues that were resolved last week, starting with the registry configuration items, STS 5057, corrected an issue of an invalid validation warning that appeared It said transcatheter replacement is marked yes, and implant type is not marked transcatheter device or mitral leaflet clip. These fields may be inconsistent. So that warning message was coming up when it should not have been, and that has been resolved for version 4.20.2. Also, STS 4731, specific to version 2.81, there was a critical error triggering incorrectly for operative mortality, which is also now resolved. Next section, STS 4068, for the risk-adjusted dashboard. There was an issue where the case list for the failed to prescribe all eligible NQF endorsed medications section was showing more cases than the number displayed in the report. So for example, the report said there was one case in that section, but when you clicked on it, the case list was showing over 20 records. And so that issue has been resolved. And then STS 4450 on the participant dashboard, the non-analyzed dashboard, that was just identifying deep sternal wound infections and surgical site infections as missing, despite them having been documented on the case form, and that has now been resolved. And then a couple updates in regard to the MIPS performance measure report. Updates were made to measures 226A and 226C, the tobacco use screen and cessation intervention, to correct an issue where it wasn't placing former smokers in the performance MET category. And so that logic has been updated, so those will be properly categorized. And then STS 4363, the MIPS report parameter page now is set to default to the 2020 reporting year to help you navigate and run that report just a little bit more quickly. All right, next slide. Some enhancements that were made in last week's update for the non-analyzed dashboard, STS 5016. We made some performance enhancements that have been applied that should help that report to generate and run a little bit more quickly for you. And then a couple new reports, the risk score match report that is now available, and it will allow you to review records included in version 2.9 and 4.20.2 data versions. That report is now posted. The report overview, rather, is now posted under the library section. So if you want information about how that report works, head to the library and pull up the overview document for the risk score match report, and that should give you the information you're looking for. Also, the ACSD surgeon composite report is now available for surgeons who have elected to participate in receiving that report. And a report overview for that has also been posted in the library section. And I believe if you want to participate in that report and you haven't already elected to do so, you can contact by email the STS database support team at stsdb@sts.org. And they should be able to help get you set up with access to that if you need it. And then last slide, just a couple quick notes here. First, our usual reminder that if you did submit a ticket that we didn't discuss in today's overview, please understand that we are looking into it. And if you do have any questions, please follow up with on the ticket itself so that our agent can look into that and get back to you with more information. And then also, we didn't include any 20 January release notes on this. So we are currently reviewing items that are under review for updates later this month. And once we have that information ready for you, that will be posted in the notifications section for your review.
Great, thank you, Joe.
Thank you.
And the Iqvia Support Plan, if you have open tickets and you have questions about those, please include your PID, which is your participant ID number, in all communications with STS and Iqvia. And if you'd like to put any questions into the Q&A regarding open tickets, please include your ticket number so Iqvia can quickly access those and gives you some feedback. There's my information, and then information regarding database operational questions. Either of these emails will work for you. And we're going to go to Q&A now. Let's see. The first question I think somebody already answered, and it was about if you have questions about direct data entry, please email stsdb@sts.org. And then the same for if you'd like to have a surgeon. Jane has put an answer in there for those questions. The next question is, do you have dates for AQO 2021 yet? And we do have dates for that. I believe it's the end of, let me pull it up. So under STS National Database, Registry's STS National Database, if you scroll down here is where you'll find the information about the AQO, which is Advances in Quality and Outcomes to Data Managers Meeting. And I don't see the dates yet posted, but I do believe we have them. And if Emily is on, maybe she might be able to help us with that. I'll give her a second. She might be busy. Let's see if she's there. And the next one is from Donna. Please, how to get and print her harvest reports? Iqvia, do we have written instructions to help Donna with that posted on?
We do. This is Melanie. Happy New Year, everyone. If you were to access the library, there is a resource that's available for the ACSD risk adjusted reports, and that will give you instruction on how to export and print the report.
Sure. So in the Iqvia library, and then it will show you how to do that.
Correct.
Thank you. When is our next benchmark report from STS due to be out? So it is expected to be in beta testing this week, by the end of the week, assuming everything goes well the next couple days with STS review. So it should be out fairly soon. We hope to have it out within the next couple weeks. From Priya, I have a couple of questions. Is H1 2021 going to include a rolling 3-year data for Cabbage? And will Iqvia include or exclude COVID patients in the Dqrs? Thank you. So we don't have an exact date on the rolling 3-year Cabbage risk model composite measure that's to be out. It will be released in 2021, but we are having internal discussions related to that to decide when it should be the best time to roll it out into the reports. The second question is, will Iqvia include or exclude COVID patients in the DQR? So at this time, Iqvia is including COVID patients in your reports back. They're not performing any type of analysis, so those patients are not being removed, but they will be removed from the analysis at DCRI, and then Iqvia will be reporting them back to you using separate filters in your benchmarked reports. And Cindy Piotr says, thank you, Melinda, for the fabulous additions to the training manual. Now, next question, can we get the unnecessary child fields in the AFib procedures grayed out if we only check AFib obliteration? So the way the parent-child field parent relationships work is that we have to have one parent, which is was a AFib procedure performed, and that opens up those 4 other fields. So you do have to answer those, unfortunately. I may have missed it. Was there an update on star rating release for the latest harvest? So the latest harvest, which with the star rating, was harvest 3, and that should be in, assuming that all goes well the next couple of days with the STS review of the H1 and H2 benchmarked, and the H1 and H2, H3 benchmarked, and the H3 star rating reports. Assuming all goes well with STS review, we will open it up for beta testing by the end of the week or very early next week, and should have those, we'll run it through beta testing for a couple of days and then should have those released out to sites fairly soon. How would you document left atrial appendage oversewing on section M1?
My first question to Rhonda would be, is that an amputation with oversewing?
And so you would need more information to help her with that.
That's what I'm thinking, because generally speaking, it's always an amputation with oversewing, and that would be captured as an amputation.
So if you have a specific question or a specific part of your op note that you'd like Melinda to review, you can send it in to the FAQ mailbox. I'm not sure, Kimberly, I'm not sure on your comment. It says if they are not sure, check the specimen's pathology. I'm not sure what that means, but if you'd like to clarify, please put it in the chat, or I'm sorry, in the Q&A. So for 5300, we still put 777 in the model number field, then yes to the temporary field, correct? Yes, that's right. 777 is the FDA other approved code. So let me pull that up so people can see that. See if that pulls it up. So these are all the codes that are available. This is your data specs. These are all the codes that are available. And 777 is the code for other FDA approved. This code here, other US FDA approved. So you would code that as yes, and then you would capture yes for a temp YN2 field to identify the ELS 5300 physioannuloplasty annual ring device. We seem to have an issue with stroke adjudication post-op. We are coding per STF definitions, but our surgeons sometimes don't think a patient has had a stroke or document patient has had a TIA with no residual symptoms. Does the surgeon have the ability to say a patient has not had a post-op stroke if we can code a stroke based on definition? I'll let you take that one, Melinda.
Thank you, Carol.
You're welcome.
That's kind of a loaded question. I think that first of all, you need to follow definitions. And I'm sure that there's probably some neurologist that has seen this patient, and you would want to definitely look at the neuro notes and the CT scans and MRIs or whatever other procedures they did to verify that this patient did or did not have a stroke. And sometimes it's difficult to be a data manager because you have to point out things to surgeons that they may or may not like you to point out to them. But we do need to try to follow the definitions. And if you have questions that you need assistance with, you can certainly send it in to the FAQ mailbox.
Great, thank you. Is temp YN1 being used for anything else? Yes, it is being used for this insertion of a device that cannot deliver a minimum of 5.0 liter of flow for the under mechanical assist devices. So if this one we had talked about earlier, this started with July 1st cases, and it has to be inserted using open surgical transaxillary or transaortic during the index cardiac operation. More information on this field is included in the training manual. This has come up a couple times when I ask a surgeon about Carpentier class for a patient with mitral stenosis. They say mitral stenosis is not typically described by Carpentier class. Has anyone else had come up with that? I explain I cannot get the MS etiology lesions without choosing Carpentier classification. So I think we have talked about this at AQO, and correct me or step in, Melinda.
Well, I think that this has come up a couple times in the FAQ mailbox, and you know, I know what your surgeon's saying. It's typically not associated with mitral stenosis. It's typically more associated with regurgitation, but restricted type or rheumatic type certainly could be stenotic type. So I think that, you know, again, I would clarify with the surgeon and do the best you can to get the class. Or at least the cost.
Yeah, Dr. Badwar instructed at AQO that if you only have the etiology, you can code class based off of the etiology. However, if there's a etiology that spans multiple classes, you need to clarify that with your surgeon related to leaflet mobility. So for example, if you had, we could say congenital is 2, where we have a type 3A restricted leaflet mobility, which is systole and diastole, or we have a mixed lesion, which is type 2 and type 3A, could both be coded as congenital. You would need to clarify with your surgeon regarding the leaflet mobility. If it's restricted leaflet mobility only, then you would code that as a congenital etiology under class 3A. If it's increased leaflet mobility and restricted leaflet mobility, then you would code that under mixed lesion. So you can also work backwards to get the type of Carpentier. I was told that Iqvia is not resolving the issues with the correct MIPS data is not being calculated. I think Iqvia, would you be able to take this question from Beth?
Yes, I can certainly do that. It's Melanie. I am curious to find out who shared that information, and that's not correct. We are, if there are issues that have been reported to us, we are addressing and making sure that the correct information is being presented on the report. Joe did report that we updated the measure that is related to tobacco cessation. So again, if there are any outstanding logic updates that's related to that, yes, we are addressing that. But if you have a ticket number, Beth, or information that you can share with us so we can follow up. I'm not sure where the information, that information came from, but if you can let us know, and then we can follow up also to make sure that everyone is clear on making sure that, of course, we're addressing those items.
Thank you, Melanie. Another question on the risk adjusted reports for the first and second quarter of 2020. So those should be coming out in the next week or so. We have, assuming that all goes well, the end of this week with the STS review and beta testing, the end of this week and next week, then we'll have a better idea of where we stand the end of next week with those reports. Melinda, I'll let you take this one from Jenny Anderson. She says, can you please review the left atrial appendage information again? We have surgeons that frequently use the cutting stapler, and I have been capturing left atrial appendage obliteration epicardial staple. Is that correct?
Yeah, that is correct. And that's sort of the example that we talked about. So if you look at the training manual, you can pull up sequence 4139, Carol. When you look at your choices for the obliteration, go up just a little further in the training manual. Up a little further, 4139. Thank you. So you will see that these choices are an epicardially applied occlusion device, such as an AtriClip, a staple, which includes cutting and non-cutting, an epicardial suture, an endocardial suture, which can be oversewing, and maybe that's what Rhonda was talking about earlier. We don't have enough information to answer that question. And so those are the choices for obliteration. When you go down to sequence 4142, we're just looking for amputation or oversewing with amputation in that particular area. Carol, do you have something to say? I see you just popped up a little.
Yeah, I think we just need to review the cutting stapler with the surgeons and maybe provide some clarity, because my understanding is that was a method of amputation. So
I know, but then when they wrote this specifically, they put it under obliteration.
yeah, and I think it depends. I think like how your FAQ said that if it is, if there's any part of the left atrial appendage left, then it would be obliteration. But let's just, maybe we should just clarify that.
We can ask them again to clarify that, because I understand the issue.
Okay, thank you, Melinda. Next question, will other metrics be added to the dashboard such as operative time, CPB times, aortic cross clamps, and length of stay? Yes, those will all be available with the benchmarked report when that comes available. And then updated with each harvest report. I have a question regarding MIPS. Okay, so I think MIPS questions are being deferred or sent over to Donna McDonald. So we could put her email in the chat box if you'd like to reach out to her with your question. For the removed COVID patients, will it be patients that were positive at any time prior to surgery during index hospital stay or post-op? Yes, right now it's any time that that patient had a positive COVID PCR test that they will be removed from analysis if they were coded as any of the yeses. And right now we do not have a time frame that we're limited to. The surgeon leaders of the STS are reviewing the data to see if we need to add a time frame or how we'll approach this with future harvests. But for this purposes of this harvest, there is no time frame, and for purposes of abstracting data, currently there is no time frame that's restricting us to code a yes or a no. Will Iqvia be developing time parameter presets by quarters and calendar years rather than only the 18 to 24 month intervals currently available? And I think we actually had long discussions about this with many people, but I'll let Iqvia take this.
We would just need to follow up in regards to those specific requirements. I think we initially just started out with those identified timeframes. So it's just between STS and Iqvia to just review the breakout of how we would like to have that information displayed. So we can add it to our discussions to make sure that we cover that.
Thank you. Another one for Iqvia. Is Iqvia still considering a change to the operative mortality on the non-risk adjusted dashboard?
Yes, we currently are looking at making updates to that, and that's on, of course, the non-risk adjusted and non-analyzed dashboard. We'll have another update regarding that, I believe in our next webinar session or user group session, we'll have information regarding that.
Great, thank you. Are transcutaneous mitral valve procedures to be included in the database? They are not required to be included in the database. They should be entered into the TVT database. However, if you'd like to double capture them, you can still enter them into the STS database. We never received our invoice. I sent a request of copies for database invoice on Monday, but still haven't received them. So Deb, if you want to email me, I'll pass your email over to our finance team and ask for Sean to send you the invoice. And my email is on. Go ahead, Jane.
Could I jump in really quick regarding the invoices? Yes, thank you. We've received, the volume of requests that we've received has been pretty high. And so if you haven't heard from us in a day or two, please give us some time to work through our emails. We're working on them as in the order in which they've been received. So be assured that we have your emails and we're working through them as quickly as we can.
Great, thank you. Can the data specs be reviewed for operative mortality? Our vendor software is only allowing us to answer operative mortality if the patient was discharged to hospice or discharged alive after discharged. So when choosing died in hospital, the child question of operative mortality does not open. So that the data specs are working correctly for that field. And the reason we made that change in version 2.9, and the reason we did that is because folks were coding operative mortality incorrectly. So we had to use the data specs to kind of ensure that our data was getting in correctly. It is correct. The way to calculate total operative mortality, which is defined as a patient who dies within 30 days of surgery if discharged alive, or who dies in hospital if not discharged at any time, it could be greater than 30 days, is to look at your, hold on, I'll pull this up here, is to look at your status at hospital discharged if they died in hospital. So you would look at this field, and then you would also look at the status. Where did it go? Oh, same field, discharged alive, died after discharge, or died in hospital, discharged alive, died after discharge, and then the mortality date has to be within 30 days of the surgery. Mortality, operative mortality was being coded incorrectly, so we had to make a change in how we were collecting that from 2.81 to 2.9. So it's been this way for a couple versions, for at least a version, and the start of version 4.20. Jane, can there be an option for surgeons to share the report with data manager in the future consents?
Not at this time, no. Thank you.
Can I hear what you had to say about the stroke question above again?
So that was the question. That was the question about surgeons basically saying the patient didn't have a stroke, even though there appears to be evidence in the medical record, CT or neurodeficits or something that meets the definition of the patient having a stroke.
Great. And then the follow-up to that is that many times the neuro CTs and MRIs, the results are ambiguous for existing patient, for existing, pre-existing with CVD strokes versus acute post-op strokes. If the neuro reports are not specific, what would you suggest?
Well, you know, you have to look at each scenario case by case. And at times I've taken this to surgeon leadership if there's been a great need for it, and had the surgeons tell the site whether this is a stroke or not. And you know, it's really hard to answer generalized questions like this in front of 400 people without having a scenario in front of you. But the important thing is to, if you have imaging results that approve a stroke post-op, or you have deficits that last longer than 24 hours, then both of those things meet the data definition for stroke, for our definition of stroke, for the STS registry definition. So
Thank you, Melanie.
yes.
I think it's really important to work with your surgeons and urologists and to have that communication open with them. The next question is from Beth, and she says, the echo absolutely never reports as leaflet mobility increased restricted. So do we never classify, therefore always listed as unknown? Well, actually, Beth, we have these really nice surgeon worksheets that you could have your surgeon fill out, and you need to work with your surgeon to get them to dictate that information for you. Next question, if the surgeon consented to the composite report, will they be notified that it is now available? Jane Hahn, do you know how that's working?
I'm sorry, I was on mute. I don't believe that they receive a notification. I think it just appears in the platform under the operational report section when it was made active. But if any of your surgeons have questions regarding, you know, their password resets, user credentials, or anything related to the Iqvia platform, they can email stsdb@sts.org, and we'll be sure to help them. And we can also check to see if they've actually submitted consents, because many feel that they have, but we haven't received them. So we're happy to work through those issues with them. If you'd like to have them email us, or you can email us on their behalf, and we'd be happy to follow up with them, whichever works best for you. But we're here to help.
Thank you, Jane.
Sure.
And Melanie, this is from Beth regarding the MIPS. She said that JJ just sent an email saying that MIPS data errors may be looked at in a future enhancement.
He sent, okay, all right, thank you, Beth. And I did also receive her email too, Carol. So you also
great.
have that.
Okay, thank you. From Tabitha, what is the last published harvest report that we have? The last published risk-adjusted report is Harvest 1 of 2020, the benchmark report for Harvest 1 of 2020, and I'm sorry, yes, the benchmark report for Harvest 1 2020, risk-adjusted and benchmarked for Harvest 2, 3 2020. is open in our UAT environment for STS to review, and then we'll be going out for beta testing shortly. So they're coming your way. And just to clarify, in the past, that country is not PHI and should be available to export and harvest files. Country is not considered protected health information. Correct. I used the STS, Michelle, I apologize. I don't understand your question. I see that there's two parts here. It says, I use the STS risk match in for a CAB PVI, left atrial appendage, and ASD. I keep hitting enter, but the patient did not match. I'm not sure, if you're referring to the Iqvia platform, I would suggest submitting that as a question to Iqvia for them to check into.
And if she can confirm, because I'm interpreting that she's using, there's a tool on the website, correct? The STS risk calculator.
Mhm.
I'm not sure if that's what, so Michelle, if you can just clarify it, because there's nothing, it's for the report, it's informational only. There's nothing that they could interact with, right? Like there's nothing to click. It's only viewing the score matches.
Right. And then Pani posted some additional information regarding MIPS in the Q&A for you, Melanie.
Okay, it's just clarifying what was being said in
Okay,
regards to
thank you.
Yeah.
From Anne, could you review how we answer NYH if the patient does not have CHF? So the reason we made that no longer NYH classification as a child of CHF is related to the functional heart failure for mitral valve patients and it being dictated. So the patient doesn't necessarily have to have CHF to have a NYHA classification provided. If it is not provided to you, then it has to be documented in order to code it. So if you don't have anything coded, then you can't chart any classification for that.
I think the important thing to remember is that NYHA class is now being used to most frequently to describe functional class of patients. So you don't necessarily have to have heart failure to have an NYHA functional class. And quite often mitral valve patients fall into that category. They may not have ever had CHF, but they do have a functional class of, let's say, 2 or 3,
right,
which is why we need it.
That's correct. So, and if there's nothing documented for NYHA, then you would code not documented. The classification has to be documented by the surgeon.
Correct. But I think typically so many times people have thought that you can only have an NYHA if you have heart failure, but that doesn't exist anymore. Now they're using it for functional class of patients.
Correct. So Melinda did a great job providing some information here in the training manual on that for you, Anne. What's the difference between non-analyzed and analyzed benchmark report? So non-analyzed is just your raw data. There's no statistics added to it. There's nothing done to it. It's just raw data. There's nothing applied to it. The benchmark report, analyzed benchmark report, the data has been cleaned up when it goes into DCRI for analysis. And these analyzed benchmark reports, they're looking at your data compared to the STS National and your like group outcomes. Can you please tell me what dates are covered in the latest STS reports for Harvest 1 2020? So Harvest 1 reports include data with OR dates through December 31st of that previous year. Do I access the STS reports on the Iqvia? Yes, it's underneath the operations report button on the left-hand side of the Iqvia platform. Will the H1 2021 include the 3-year data? If we haven't made a final decision on that, and we're in internal discussions about the 3-year data for the Cabbage report. I received an unmatched risk in Iqvia for a patient that I am calling a Cabbage. So I have a risk in my database, but Iqvia shows no risk. So I think Michelle should probably submit that
Yeah.
to you,
Yes.
you all for a ticket.
Yes, definitely. So we can review that further.
Thank you. Can you repeat the information you shared about the upcoming STAR benchmarked reports? Did you say 2020 Harvest 1 STAR and benchmarked and 2020 Harvest 2-3 STAR and benchmarked report may be available soon? So Harvest 1 STAR report is available. That's your risk adjusted. So by STAR and risk adjusted, we'll use the same terminology. So Harvest 1 risk adjusted report is available already in your Iqvia platform. Harvest 1 benchmarked report, Harvest 2 and 3 risk adjusted and benchmarked report will be available soon. Even if it's a replacement and not a repair, we code no. That's referring to the mitral valve insertion of ELS 5300. And yes, still code no, even if it's not a repair. So if a different annuloplasty ring, mitral annuloplasty ring was implanted other than 5300 PhysioFlex, do we still have to enter no in temp YN2? Can we just leave it blank? I would ask for you just to put no in there just so that we can cover all the bases if there was a device inserted. When was the risk report made available in Iqvia? So the Harvest 1 risk report, Harvest 1 2020 risk report was made available in Iqvia prior to AQO. I'm not sure of the exact date. Wait, I thought we were no longer using the aorta codes. So you are no longer using the aorta codes. Those codes that we showed you were for the valve devices. The detailed level review does not make sense to me where the endpoint is blank, proc ID is blank, and the participant value is blank, but it's a match. What does that mean?
Hi, this is Melanie again. So when you end up with a blank entry in which the proc ID is not assigned, that means that the case does not have enough information to generate a proc ID. And that is also what your vendor is returning, and we are returning the same. So in that instance, it's a match. If it was identified that the Iqvia platform was able to determine a proc ID based on all of the different calculations, it would return a proc ID and it would return an Iqvia value. The participant value would be empty. And this information is also covered in that report overview for the risk score match, and that's available in the library. It does give you the context of why you would see blank entries on that report.
Thank you, Melanie. That's helpful. Who do I contact for a specific report from the STS on STAR rating comparison? So Pat, if you could reach out to me, I'm not quite sure I understand what you're looking for. We don't do comparison. We have your ratings, your STAR ratings. And if you're looking, I'm not sure which specific report, but please reach out to me and I'll try to help you and get you into contact with the correct person. And then will the benchmark report be a full printable report similar to the old reports? And yes, you'll be able to PDF those reports and print them out. You'll also be able to download them into PowerPoint presentations. And we went over that. I can't remember exactly which one, but we have gone over that in a recent webinar where Melanie walked through all of those features. And maybe we can do that again for the next one, Melanie, as well as a refresher.
Yeah, sounds good.
Okay, thank you. Will we receive an email when the reports are available? You'll receive a party invitation from the STS that the reports are available. Just kidding. Yes, you'll receive an email. We'll let you know when those reports are available. And it looks like that's it. Are there any other questions that we can answer for you? We did pretty good. Melinda, do you have anything? Melanie,
my-
team?
Nothing here.
Go ahead, Melinda.
I said, no, ma'am, I'm good.
Okay, awesome. All right. Oh, hold on. Can you post information regarding COVID patients being removed from analysis so we can have it for review, please? So this was in the information that was sent out in April, on April 1st or March 31st, and it was also posted in the presidential address from Dr. Durrani, the STS president, regarding the removal of these patients from analysis.
And it's also in the training manual too.
Yep. Thank you. All right, thanks everybody. I hope everyone has a happy new year, and we'll talk soon. Our next webinar is on the January 20th at 2 p.m. So we'll talk to you then. Oh, I know, one other thing before you go. We are starting the upgrade process, believe it or not, for version 4.23, which will go live hopefully January 1st, 2023. And we'll be looking at the frequencies from version 4.20, what we have, probably a year's worth of data. We'll pull at the end of June. So we're going to start the upgrade process in mid to late spring of this year for 2023. So if you have any suggestions or questions or anything you think would be helpful related to the current version that we need to update in the next version, please email me and or Melinda and let us know so we can start putting some lists together. We did quite a big revision on 4.20, but I know that it's not perfect. So if you have anything you can share with us that you'd like us to even think about, or any new procedures your surgeons are doing, or techniques, or things that maybe aren't, you're not able to capture correctly, or you're having a difficult time that we can make better, please email me and let me know so we can put that all together. Other than that, thanks everybody, and I hope you have a great day and happy new year, and stay safe and healthy and take care. Thank you. Thanks everybody.